See. Next, we will go ahead with the talk which was supposed to be given by Dr. Vanathi. She's busy in another session. So Dr. Abhijit Peniwal will be giving the lecture. He's from RP Center AIMS from the Cornea Refractive Surgery Unit. Simple Limbal Epithelial Transplant SLET. Tips and tricks.
So, good morning everyone. I'll be giving my talk on tips and tricks of simple limbal epithelial transplantation. No financial interest. So, going briefly into history, already it has been discussed, but several techniques of stem cell transplantation have evolved over time. Conjunctival limbal autografting was first introduced in 1989, but it led to large areas of stem cells being removed from healthy eye and led to iatrogenic stem cell deficiency. So in 1997, cultivated limbal epithelial transplantation was introduced. In this, a small lenticule was removed from healthy eye. It was grown in laboratory, but it still needed sophisticated laboratory. So in 2012, Sangwan et al. Came up with in vivo growth of stem cells, that is simple limbal epithelial transplantation. So these steps I'll be discussing in my video courtesy Professor M. Vanathi. So we mark around 4 mm area, preferably in superior limbus, and we cut with a blade both on the conjunctival and on the corneal side. We want to include a part of stem cell, and several techniques have been described, but here we have cut with blade and we'll dissect. Blunt dissection is carried out using the crescent blade, and it is cut using Vana scissor, and it is stored. So this is the diseased eye, and you can see there is no symblepharon, and we'll do 360-degree peritomy and achieve hemostasis. Then we'll do some pannus removal is done, and you can see there is total hemostasis. Then amniotic membrane is put with basement membrane side up so that it sticks well, and it is trimmed to the size, and no folded areas are there. Now the lenticule is put over it. It is cut into several pieces. The pieces should not be placed in the visual axis and should not be placed as limbus either. They are placed slightly inside. If placed at limbus, that may lead to long-term scarring or a visual axis. So they are placed all around. They are placed epithelial side up, which can be seen. The white side is the stromal side. So epithelial side up, we try to place, although the stem cells will find their niche even if placed other way around, but we try to place them epithelial side up. So they are placed all around, and fibrin glue is applied then to secure them. So, and then a bandage contact lens is put. In children, we can even do tarsorrhaphy so that they don't rub the eye. Some other steps I would like to say. So firstly, we prefer superior limbus because it is said to have more stem cells. And secondly, if the diseased eye has symblepharon, we can go with conjunctival autograft along with the SLET procedure. So that is one, and the eye should not be inflamed. We have to make sure that eye is not inflamed, the inflammation is under control. And post-op, we give prednisolone acetate drop in the diseased eye. Some people prefer to give prednisolone in the normal eye also in which lenticule has been removed, but we usually don't give it. And since it is autologous, so the steroids can be stopped after some time. That is the advantage. So several studies have proven superiority of this procedure. Sangwan et al. In their pioneer work, they reported successful primary outcome procedure defined as completely epithelialized, avascular and stable corneal surface at 6 weeks in all 6 patients. And best criteria visual acuity improved to 20/40 or better in 4 eyes. Basu et al. Reported 2/3 of successful cases attained 20/60 better vision, and over 70% children showed complete epithelialization. And Gupta et al. Reported anatomical success in 80% and functional success in 85% of patients. It has also shown successful result in case of previously failed SLET and have shown to a better outcome than repeat SLET in such patients. And it improves outcome of sequential keratoplasties as shown by study by Deepti Singh et al. It reported anatomical success 72% of eye, visual acuity improvement in over half of the eyes which underwent DALK post-SLET. And there are several modifications described. Amesco et al. Described the use of double-layered AMG in which limbal stem cells could be sandwiched between the 2 layers. And Vajrani et al. Reported customized SLET. They first did SLET in a patient. It led to improvement of ocular surface. It then led to another mini SLET which was applied to bare corneal surface with fibrin glue. In the second step, they did not use amniotic membrane. Kalki et al. Explored the concomitant SLET with excision of pterygium, and mini SLET has been described for treatment of pterygium by Bongetes et al. And Maligan et al. Proposed glueless SLET. In this, limbal stem cell explant were inserted in short oblique tunnels in corneal periphery, followed by placement of amniotic membrane on top. Thank you. Any questions?
Thank you, Abhijit. That was a wonderful talk. In your result, you have shown that the limbal stem cells that have been harvested and then placed over the cornea directly, and one studies have shown that over the empty membrane graft. So, is there any randomized studies was done between this one, or what is your take on it?
So, amniotic membrane provides a substrate for epithelial growth. So ideally, it should be used. In the study in which they did not use, they have already already improved the ocular surface once with amniotic membrane. So ideally, amniotic membrane provides substrate, and it is shown that SLET is a true regenerative procedure because the stem cell marker ABCG2 has been noted after surgery. Like 6 months after surgery, it has been noted. So it is a true regenerative procedure which led to introduction. It not only epithelializes, it leads to introduction of stem cells which stays there. So ideally, it should be used with amniotic membrane.
Yeah. Okay. Thank you. Yes, please.
It will stick better if the stromal side is down. Otherwise, even if not done, then it is rough. The stromal side would be a bit rough. Basement membrane side will be
You can use a cotton swab, wet cotton swab, and place over the amniotic membrane. If stick, then it is stromal side. Usually the epithelial side is smooth. It doesn't stick it. Yeah.
So the stromal side will stick better, it is said, though it will not come out. We did put glue in below that. We should do because because most of these patients are children, they may rub eyes. So it's better to suture around also, and we can put glue also. In this case also, I have edited that step. The glue was put beneath it also. Yeah, so with the crescent blade, the pannus was removed a bit. Okay, partial keratectomy was done to raw the surface.